Hi, my name's Michelle, and I'm here to present a case study on Stacy. She's a 38-year-old woman with multiple sclerosis who presents to the office today to discuss some medication changes her neurologist has recommended and is seeking antibiotics for sinus infection. First, a little bit about multiple sclerosis. Multiple sclerosis is an autoimmune disease, and the body's immune system attacks the myelin, or the fatty substance that coats and protects the nerve fibers in the brain and spinal cord, leaving lesions of demyelination. The clinical course varies widely from patient to patient, and currently there's no cure, but there are now disease-modifying drugs that can help decrease the frequency and severity of exacerbations or relapses of disease. It's diagnosed by MRI, where demyelinated areas are seen in the brain and or the spinal cord. The most common symptoms associated with multiple sclerosis are sensory symptoms in the limb and face, feelings of electrical shock or tingling or numbness, motor weakness in the limbs, diplopia because of weakness of the eye muscles, gait disturbance related to the sensory symptoms and the motor weakness, bowel and bladder dysfunction, muscle spasticity, and pain. So Stacy was diagnosed in 2001. She had presented with right leg weakness and diplopia, and at that time she had an MRI which showed cervical lesions. She was diagnosed with relapsing remitting MS, and she has minor relapses 2 or 3 times a year that she pretty much recovers fully from, and those last 2 or 3 days, and she recovers quite well. But she's had 3 major relapses since diagnosis that she has not returned to her baseline from, so she's had a progression of her disability. She had an exacerbation in 2001. She had fallen and fractured her right ankle and had to have surgical repair, and the stress of that took a lot out of her. And she had more weakness on the right side and more problem with gait instability. And then in 2009, she had been the primary caregiver for her mother, who was suffering with pancreatic cancer, and she cared for her for about 6 months until her death. So the stress of being a primary caregiver and the stress of her mother's death seemed to initiate that exacerbation or that relapse. And then in 2016, she had fallen and fractured her left ankle, and if you'll notice above her right side is her weak side, so she had a double whammy of the injury and surgical repair of that left ankle, which was her strong side. So she had to recover from this fracture, but also relied heavily on her weaker side, or her affected side. And so she really has seen an advancement in her disability. Her gait is off, her activity tolerance has been decreased, and her depression has definitely escalated, although she has started to recover a little bit mentally from that. Diagnostics, she has had multiple MRIs which continue to show cervical spinal lesions, and there have been a few new lesions with the last 2 MRIs. And then JC virus antibodies is negative, and the JC virus, or John Cunningham virus, named after the first patient it was identified in, is a very common virus. 75 to 80% of Americans carry the virus, and it isn't a problem. But in patients with multiple sclerosis, because of the immunosuppressive medications they're on, the virus can infect the white matter of the brain, where it exacerbates the progression of demyelination, and it can lead to all sorts of nasty symptoms, which we will talk about, including death. So there's some treatments for MS that, if you have the JC virus, increase your risk of developing PML, or progressive multifocal leukoencephalopathy, which can be deadly. So her past medical history: she has relapsing remitting multiple sclerosis, diagnosed in 2001. And she has sinus allergies. She has sinus infections 1 to 2 times a year at the change of seasons. Past surgical history are in 2005 she had that right open reduction internal fixation of her right ankle, and in 2016 she had an open reduction internal fixation of her left ankle. She has no known drug allergies. Her current medications are oxybutynin, 5 milligrams twice a day, and she's on that for some bladder urgency and some incontinence, which is very common in MS patients. She's on duloxetine 60 milligrams a day, and she's on that for management of her pain as well as some depression. She's on gabapentin 300 milligrams 3 times a day, and that's for her neuropathic pain as well. She's on baclofen 10 milligrams 3 times a day for spasticity, and she typically takes it 3 times a day. Sometimes it's twice a day, and if she's having a really bad day with spasticity, she'll take some extra there. She also has tizanidine or Xanaflex 4 milligrams 4 times a day as needed for spasms, and she really doesn't take this very often because she feels like she just can't function without it. So she'd rather deal with the spasms when they come, or take some extra baclofen. And that's something she's worked out with her neurologist, her previous neurologist. She has a new neurologist, and we'll talk about that in just a minute. But she also takes vitamin D, 5,000 units daily, and vitamin D is thought to play a part in multiple sclerosis, but the mechanism is not completely known. She takes Tecfidera, 240 milligrams twice a day for her MS. She takes Zyrtec, 10 milligrams daily for her sinus allergies, and Flonase, 2 sprays in each nair daily. So today she comes in to discuss her neurologist's recommendation to switch from Tecfidera to Tysabri. And so we had a very lengthy discussion. She has been my patient for about a year. She moved to this area from about 2 hours away, and we've had a pretty good relationship. She also at the same time got a new neurologist, and she is very frustrated with him. She said she doesn't feel like he listens, and that she feels like she goes in there and he doesn't know who she is. And this is a patient who is really very compliant. If I ask her to do anything, she does it. And she just feels like she's not getting good care from this neurologist. She had a neurologist, Dr. Smith, who she had seen and liked very much until she was restationed here. And her previous station, she's a military wife, and her previous assignment was about 2 hours away. And she's asking if I will work together with her previous neurologist, Dr. Smith, so that she can leave this new neurologist that she has. So we actually called Dr. Smith. This was a conference call that the 3 of us had, and Dr. Smith agreed to see Stacy if Stacy would come down every 6 months to see her, which Stacy says it's a 2-hour drive. I will do that. And so we had lots of discussions about the risks and benefits of Tecfidera versus Tysabri. And it sounds like her current neurologist, who she's going to get rid of at this point, or going to break up with, was recommending this switch based on this recent exacerbation, to which Stacy says she's done very well on Tecfidera. She likes it. She likes the convenience of being able to take it at home rather than having to go in for an infusion. She feels like she's had less relapses, and that this current relapse can be explained by the stress of the fracture. So Dr. Smith has agreed to continue to see Stacy, and Stacy will be transferring her care back to her. Stacy's also requesting a Z-Pak for complaints of sinus infection. She has nasal allergies. She gets sinus infections 1 to 2 times a year. Patients with MS, because of their disease-modifying treatments, have immunosuppressive effects, so they're more prone to infections, and they can get bad fast. So she's had these symptoms for 12 days. She knows she's supposed to wait 10 days. She said it got better for a few days, and then it's been progressively worsening over the last 5 days. She has a constant headache that increases when she bends forward. She's got some green nasal discharge. Because she's been through this before, she's already increased her Zyrtec and Flonase to twice a day for the past 10 days, really without improvement. She has a low-grade temp on presentation. She's 99.2, and with palpation, her sinuses, particularly her frontal sinuses, are very tender. And in the past, she's improved with a Z-Pak, and she's hesitant to try new medications because she feels like she's on too many as it is, and she doesn't want to mess with things. She's had good effect with Z-Pak in the past. And we had a conversation about a Z-Pak is currently not the first line drug of choice, but she's pretty sure that this is what she wants. So we'll talk about that in just a minute. So while we were talking with Dr. Smith, we talked about the Tecfidera, and that which is what Stacy is currently on, and it is a MS modifying drug to which the exact mechanism of action is unknown, but it does activate some nuclear factor like 2 pathway, which results in a cellular response to oxidative stress, and oxidative stress seems to be what part of the process of creating these areas of demyelination. So with Tecfidera, we need to monitor her CBC because it can induce leukopenia. So a CBC gets done when treatment is started at 6 months, and then every 6 to 12 months. And Dr. Smith has said that she will continue to check it every 6 months, about a week before Stacy goes down for her appointments. The most common side effects with Tecfidera are flushing, GI symptoms, nausea, vomiting, diarrhea, and dyspepsia. And Stacy has had some diarrhea with this, but she had chronic constipation before, and so she feels like this is okay for her. There had been some conversation about adding a bulk forming agent because that can help with the diarrhea, but Stacy says, again, she doesn't want to take any more medications than she has to, and she's okay with these chronic loose stools at this point. Severe reactions that can happen with Tecfidera are anaphylaxis, which can happen with any medication, leukopenia, and then PML, which is progressive multifocal leukoencephalopathy. And symptoms of this can include mental deterioration, vision loss, speech disturbance, ataxia, seizures, coma, and even death. And this is more common in patients who have the JC virus. And it is a possibility with PML. It's been reported with Tecfidera. PML has been reported in a few patients, a handful of patients, but it's not a common side effect, but it is a life-threatening side effect. On the other side of the med discussion is Tysabri, which is also a disease-modifying drug, the exact mechanism of which is, again, unknown, but it is a monoclonal antibody, and it binds to integrins in the leukocyte cell wall, which prevents the migration of these inflamed cells into the functional tissues of the brain and spinal column. In patients on Tysabri, you need to monitor their MRI when you start treatment, and then again periodically to look for advancement of disease. And then you need to test the anti-JCV antibody. And patients who test positive for the JC virus should probably come off Tysabri, because the risk of PML is about 1 in 1,000 if you use the drug for more than 2 years. So it's a pretty significant risk if you're JCV positive. And then you need to monitor them closely for signs and symptoms of PML because it's much more common with Tysabri treatment, and it can cause, again, deterioration of mental function, vision loss, speech disturbance, ataxia, seizure, coma, and even death. Common side effects with this are headache, fatigue, depression, arthralgia, increased risk of infection, some GI distress, syncope, peripheral edema, And then severe reactions, again, PML, and it's much more common with Tysabri. Anaphylaxis, again, which can happen with any med. Herpes encephalitis, because it's affects the immune system, it gives you increased risk of infection, and it can also increase depression and lead to suicidal ideation. And so when Stacy first started taking the Tecfidera, her and Dr. Smith had looked at these two meds and had a lot of discussion. And Stacy really, when looking at these, people need to decide, do they want the tried and true, which is the Tysabri, or do they want a little bit more convenience? And based on the side effect profile and the risks, and the Tysabri is an infusion versus Tecfidera is a pill, they had decided to go with the Tecfidera at that time. One thing that can affect the decision is the convenience. Tecfidera is by mouth medication that you just take twice a day, versus the Tysabri, which you have to have infusions every 4 weeks. And the other piece of it is cost. Tecfidera has a cost of about $6,500 a month, which is pretty significant, but Stacy's insurance covers it 100%, and they have not given any pushback at this point. Or the Tysabri, which is about $600 a month, which includes both the cost for the medication and for the use of the infusion center. So her current issues, as she's here today, are this current MS flare following the stress event of the leg fracture. So after consulting with Dr. Smith, Stacy made the decision to continue the Tecfidera, and Dr. Smith thought a steroid burst might help reduce the inflammation and reduce the symptoms. So Dr. Smith has actually arranged for our infusion center up here to administer methylprednisolone 1,000 milligrams daily for 5 days. And steroid bursts for patients with flares can be PO with or without a taper or IV. But this is what Dr. Smith prefers, so that's what she's going with. And then as far as the sinus infection, because Stacy has had good effect with the Z-Pak in the past, she knows it's not a not the first line medication, but she's hesitant to try the Augmentin, and especially where she already has issues with diarrhea, chronic diarrhea. So after discussion, I think it's reasonable that she take a drug that she's comfortable with and that she's been on before. She knows that if she develops resistance and it's not effective, then we will need to talk about other antibiotics, but at this point she wants to try that. And she's going to continue to use her increased dose of Zyrtec and Flonase until this sinus infection has resolved. Any questions? Thank you for your attention.